Okay, so with that, I think we're actually ready to get started with the essence of what we're going to be doing today. So again, a reminder, we have 4 speakers today, and our topic is time for your checkup, decolonizing global health. We are asking that all presenters be respectful while others are presenting, and for guests to also be respectful. We'll have a Q&A at the end of each session, but at the end of each presentation, and each presenter will have 12 minutes to talk, and I might signal you at some point to give you a warning on your time, probably closer to the end of 3 minutes and 1 minute. So without further ado, let's introduce our first speaker, Mitchell Yep. Mitchell is a senior in the International Studies and General Science programs and also has minors in chemistry, Spanish, global health, and mathematics. He's a recipient of the Judy Fosdick Oliphant Scholarship for International Studies, and he has been working on observations of mobile health clinics in Honduras, a case study on El Centro de Salud Integral. So yeah, I apologize, my Spanish is non-existent. He's been working with Professor Leslie Joe Weaver and Melissa Griboyes on this project. So I turn it over to you, Mitchell.
Great. First off, thank you all for joining me. And today we are going to be talking about mobile health clinics. And mobile health clinics come in a variety of shapes and sizes. But for me, when I first started learning about global health about 4 years ago, and a lot of what I heard about global health in the media is largely crisis response. And crisis response in the form of mobile health clinics that provide services to people that are in refugee camps, people that are displaced. And I think this is a very important model and form of mobile health programming, but it also doesn't give a lot of space for other types of mobile health clinics that are viable options that are expanding healthcare services, but also including people that are often marginalized within our traditional healthcare system. So here are some other images of mobile health clinics found within the United States. Some of them are large RVs that are converted, specially converted. They have accessibility ramps, they're partitioned, but others are also trailers. And they're just it's a very nice, clean, refined look. But today we're not going to be focusing on these. Rather, I'd want to challenge our perception of what a mobile health clinic really could be and how it is still operating within a lot of different parts of the world. So when I think about mobile health clinics, and for the purpose of this presentation, it is going to be a specialized vehicle that brings healthcare services to a community. And that is very broad in its definition, but it allows medical practitioners to visit places where people wouldn't normally get dental care, or places where people wouldn't normally have routine physicals. But El Centro de Salud Integral Zoe specifically focuses on eye care. So today, this is the mobile health clinic we're going to be talking about. El Centro de Salud Integral Zoe has a large amount of services available to the public. There's ophthalmology, optometry, internal medicine. They have almost anything you can think of, but it's within a small footprint in Tegucigalpa. But I think for me, it's not their amount of services that makes their clinic important. It's their international partnerships. And I originally got involved with El Centro de Salud Integral Zoe through a US-based nonprofit, Unite for Sight. And in this process, I was able to spend 8 weeks at their main clinic in Honduras. And while there, we got to go on outreaches through their mobile health clinic. And their mobile health clinic is financed mostly by international donors, and the clinic profit itself because it is a nonprofit organization. So while there, I spent most of my time at the main clinic in Tegucigalpa, but about every other week, I would get the opportunity to go on 3 to 5 day outreaches throughout the country. I got to visit northern Honduras, central, and also southern. But today, we're going to be focusing on Guajiquiro, La Paz. And Guajiquiro is a more rural community. It's located roughly 3 hours away from Tegucigalpa, but that's 3 hours on a map. When you go and drive there, it takes way longer because the roads are just deteriorated. There are a lot of gravel, potholy roads, tight corners, and it's just the amount of infrastructure development drops dramatically once you leave urban boundaries. And that poses a big problem for healthcare services and the people that live there. It is difficult to travel 4 hours by car to get healthcare, but also if you don't have a car, that would be a day's worth of walking. And these are questions and considerations that need to be asked when we think about a centralized healthcare system. But some of the key things I found while spending a few days in this community is that it is largely agricultural based. A lot of families have subsistence farms, or they'll have some farm animals just roaming their property, and there's a large sense of community. And that was shown during our outreach program. During the outreach, it took place in a church, and it was a strong turnout. I went on multiple different outreaches, and sometimes there were 10 people, sometimes there were 30 people, but this one really showed the power of local organization. And for one day, from 8 o'clock to 3 p.m., I believe we saw around 50 to 80 people. And that is a lot of people to go through a small space like that. And so we were able to bring cataract screenings and also visual acuity tests to this community. And what would typically happen is patients who gets diagnosed with cataracts would be provided with the opportunity for free transportation to the clinic and also free cataract surgery. And while this is a great model, it has various limitations, but we'll get to the limitations later. But because the mobile health clinics are important because they reduce financial, geographic, and educational barriers. So people who live in this community might not be able to afford healthcare normally. And that is part of it is due to Honduras's specific public-private healthcare divide. This makes public clinics overcrowded, and it also makes private clinics too expensive for a lot of agricultural or small business workers. In addition, the geographic barrier poses a big difficulty for older people. And just living hours away from healthcare services, it makes visiting a clinic that much more expensive as it takes time out of a precious workday. And when we think about how people perceive healthcare, it is largely dependent on their educational status. And living in a rural community, you might not even have access to K through 12 school because you live so far away from the nearest school, or your family would prefer their younger son or daughter to work in the agricultural business to support their family economically rather than furthering their educational career. But within El Centro de Salud Integral, it's largely limited by its finances. It is inherently a private clinic, and therefore it doesn't really receive funding from the state. So when they perform these outreach programs, people don't, or when they perform these outreach clinics, they're not making money off them. It's really, they're subsidizing the cost so that people who couldn't afford them get the cost, get the service. And that is great in itself, but it has its own limitations. And these will continue to limit the efforts of the program until it is otherwise addressed. And program coordination is difficult. The only reason why we saw such a big turnout in La Paz was because we had a really nice pastor that did a lot of work on her end. She would advertise the clinic weekly, like a month or two before, and she would tell all her friends and close friends about how important and how great this opportunity is. In addition to the greater mobile health system, is that when we go and treat just specific diseases or symptoms, it's not a comprehensive care. And while we can provide these great services, we need to really think about how effective it is long-term and what it could really mean for the greater community if they only receive superficial care.
You have 3 minutes left.
Great. And so as we start thinking about what my research really means within the greater community, is we should frame what mobile clinics are and how they can be used both internationally and domestically. Something I've had the opportunity to get involved with in the Lane County is Dia de Salud, and it's a one-day pop-up health clinic that's run by Huerto de la Familia. And this is a wonderful opportunity because it provides the Latino community and just the greater Lane County community an opportunity to receive healthcare if they otherwise can't afford it, because healthcare is expensive in the United States, or if they're undocumented, it would allow them place a safe space to receive care without the fear of stigmatization. In addition to our work just in Lane County, there's a larger national and trending to be international effort to map mobile health clinics throughout the world. Mobile Health Map is working on establishing an international database of all the mobile health clinics, allowing residents who live near them to access them easily and without headache over where will it be and finding what they can afford.
About 1 minute left.
And with that, I would like to say thank you to my thesis advisors and everyone who has shaped my understanding of global health, and especially the people at El Centro de Salud who provided me this great opportunity to learn from them and share my experience with them. Thank you.
Thank you so much, Mitchell. That was really, makes me excited to dive into everyone else's projects too. It's really great. So with that, we are going to go on to our next presenter, Samantha Sidline, who is also an international studies major, minoring in Spanish and global health. This is her senior year, and she has been working with Dr. Kristen Uris through the International Studies and Global Health Program on a project titled Policy Mapping Antibodies, the nexus between immigration policy, local community support networks, and migrant health outcomes in Tijuana. So Samantha, the floor is yours.
Great, thank you so much. Can everyone hear me okay? Okay, great. One morning at the US-Mexico border in Tijuana, I couldn't help but notice a young woman holding a healthy, chunky baby with these big brown eyes eyeing me. She asked Wilfredo if I, standing there silently and somewhat awkwardly, could speak Spanish, but she replied that I could. She smiled at me and then looked directly at Wilfredo and lamented that if she only had blue eyes like mine, everything would be easier, gesturing towards the looming immigration building behind me. Passionately, Wilfredo pointed directly at my heart and asked the woman why I look the way I do and why I call myself an American. She hesitated and attempted to say something about how I must have grown up in the United States, but was abruptly cut off. No, Wilfredo adamantly said. He told her that she needed to know her history better. He told her that my people, the white people, came from England and displaced all the native people in North America and fabricated this notion of a North and a South, claiming the title American as if it's a unique identity to the United States. No, he reiterated, somos americanos. We are the original Americans, and she is not. The woman nodded her head, internalizing this information. I, too, stood there internalizing this information, and even fighting the urge to reject it. I recognized my whiteness and made every conscious effort to acknowledge my power, privilege, and positionality in the spaces I was entering in Tijuana. So my immediate reaction was not about being white. It was about being used as a physical representation of an oppressive figure. My presence in that space was a reminder of the colonial legacies of the West in today's hemispheric disparities. It was that no matter what I did, the appearance that grants me immense privilege in the spaces I occupy will also represent everything I'm hoping to uproot, separating me from my intention and my objective to learn and to listen. So that was me, an imposter American who represented the root cause of the humanitarian border crisis. At that moment, I realized I was going to be leaning into that discomfort for a long time, acknowledging that my privilege as a white person gave me the ability to go to the US-Mexico border, conduct observations, and learn people's stories with little risk to my person and without wondering how I would return to the United States. It was moments like this one that drove me to Tijuana in the first place to conduct research for my undergraduate thesis in international studies, policy mapping onto bodies, in which I explore how policy has direct effects on human health and how the policies implemented today are affecting real people in real time. I wanted to understand exactly what was happening on the ground at the US-Mexico border and what community support networks were forming to confront the urgent humanitarian crisis. While my thesis consisted of both secondary and primary research, I would like to emphasize the primary research I conducted in Tijuana. My approach relied heavily on anthropological methodology. I was initially attracted to ethnographic research because of its emphasis on the human experience, which I value as the core of my own investigations. To engage in ethnographic research and participant observation at the border, I stayed at an emergency shelter in Tijuana that I call El Refugio, with a man I call Wilfredo. I accompanied him every single morning to El Chaparral, the Mexican side of the border, where asylum seekers line up and wait for their immigration numbers to be called so they can take next steps in their immigration cases. I spoke with locals who dedicate their lives to supporting asylum seekers, as well as asylum seekers themselves. I conducted interviews with those I met and recorded field notes at the end of the day with as much detail as possible. At this time, I'd also like to mention that photographs used in this presentation are my own, taken during my fieldwork, and all quotes are from interviews I conducted unless otherwise indicated. The primary policy I analyze is one of the major immigration-related policies rolled out by the Trump administration, the Migrant Protection Protocols, first implemented in January 2019 in Tijuana. You may have heard of this policy referred to as Remain in Mexico. Under this policy, asylum seekers arriving to the US-Mexico border to claim asylum are sent back to Mexico for the duration of their immigration court proceedings. While this policy has exemptions, such as Mexican nationals seeking asylum, those with pre-existing health conditions, or those who can prove credible fear for waiting in Mexican border communities, another practice called metering affects wait times for all people reaching the border, as only an unpredictable set number is allowed to cross per day. In reality, what you may not have heard is that the migrant protection protocols have resulted in a waiting period several months long, in which asylum seekers are stuck in Mexican border communities, enveloped in uncertainty as they have limited knowledge of the immigration process in the United States. They recall the ubiquitous fears they fled in their countries of origin, and they live the duality of either being an asylum grantee or deportee. The uncertainty generated by the migrant protection protocols is harmful, and I have used other literature to extrapolate how policies like this one can be mapped onto bodies and cause adverse health effects. In this presentation, I want to highlight two concepts in particular that capture the dynamics of embodying policy. The first is a culturally specific word that I first discovered when reading about the plights of migrant farm workers in California in an ethnography by Sarah Horton called They Leave Their Kidneys in the Fields. In her ethnography, Horton connects the universal feeling of coraje, a rage that stems from the daily affronts of being undocumented, that her population expresses as a direct correlation to disproportionately high rates of hypertension among migrant farm workers. Asylum seekers in waiting experience extremely similar daily affronts to undocumented migrant farm workers in the United States: the stress of immigration, lack of work, anxiety about finances, worries about family, and the ominous threat of violence all warrant coraje and a depleted mental health state during the extended wait time in border communities. Secondly, the interrelationship between policy, health, and other relevant factors like nationality or race culminate into a holistic understanding of migration through syndemics, which are defined as the adverse interaction of diseases of all types that are most likely to emerge under conditions of health inequality caused by poverty, stigmatization, stress, or structural violence. Once again, the migrant experience in sending communities, in transit, and in border communities reflects the conditions that create a syndemic, in which disease clustering of multiple conditions exacerbate each other. For example, depression, hypertension, and malnutrition might be commonalities among asylum seekers in waiting, each condition exacerbating one another and resulting in more negative health outcomes. Future research might consider defining a specific syndemic of migration and understanding if it is applicable solely to the US-Mexico border or if it is applicable on a global scale. And while I don't have time today to discuss in detail the dynamics of the US-Mexico border, I do want to mention one theme in particular that stood out to me during my time in Tijuana. To illustrate the informality which pervades the asylum seeker experience, I want to describe what is happening in the photograph pictured in the lower left circle here. On this fence is a haphazardly taped piece of white paper with Sharpie scrawled across it, with a number that ironically happens to be one of the most important pieces of information asylum seekers need as they wait. In order to advance their asylum cases, asylum seekers need to be present at the border at this location when their numbers are called. The problem is, asylum seekers arriving at the border won't hear their number called for at least 3 to 4 months and cannot access any information about the status of the numbers except at this fence corner where someone tapes an updated number. This example alone shows the informal nature that is becoming asylum and also implies the logistical issues and stress associated with this type of uncertainty. To combat this informality and the uncertainty that comes along with it, Wilfredo hands out migrant guides and brings them with him to El Chaparral every morning. These guides include critical information that asylum seekers may not be able to access anywhere else, including lists of shelters, food kitchens, and answers to some common questions about the wait and the asylum process entering the United States. People like Wilfredo are those who make up what I name the local community support network of Tijuana. Not only does Wilfredo show up to El Chaparral every morning, 7 days a week, by 7 a.m. at the latest, but he and his partner fill a niche need for asylum seekers in waiting by providing an emergency shelter. El Refugio helps those who have nowhere to go upon arrival in Tijuana, or those who show up to the border in anticipation of crossing after months of waiting, only to find that no numbers were called. If asylum seekers aren't spending a couple of nights at El Refugio, they may be enjoying a meal or getting refuge from the streets for an afternoon. Wilfredo connects asylum seekers to other community resources, such as volunteer-based clinics and legal services, and helps them pay for a taxi ride to a shelter or get some hygiene items at the store. Another example of support that unifies the community and shares threads of hope is the Border Church in Playas that operates bi-nationally over the border wall. I watched as the community came together to construct the mobile church, to adapt to the unfortunate news that Customs and Border Patrol would not open a section of wall to allow churchgoers to meet at the Mexican wall, and to pray and preach peace, love, and restorative justice. This service was a reminder of the importance of solidarity, punctuated by the art decorating the Mexican side of the wall with messages that say, in some way, we are all migrants.
You have about 2.5 minutes left.
Recalling the feeling a migrant might have when he is stripped of his own agency, coraje, I want all of us in this space to think about moving forward in solidarity with the privilege we do have to act. We now know how policies like the migrant protection protocols have begun to shrink the asylum system in the United States. As we speak, harm is being caused with COVID-19 as a scapegoat, allowing children, families, and sick individuals to be deported, more people to be detained in unhealthy conditions, and causing the complete halt of asylum cases being processed at the border. With this knowledge, we have a collective responsibility to practice active allyship, stay informed, and stand up for the voices that are institutionally silenced. It is my intention with ethnographic research to ensure that the human voice is the pinnacle of these conversations, and I hope that the community support networks in Tijuana can inspire similarly supportive networks here at home. I would like to thank Dr. Kristen Yaris and the people at El Refugio for all of their support in my research endeavors and my thesis project. And thank you all for sharing this time with me.
Kenlei, you're muted right now.
Of course I am. Thank you. So thank you again, Samantha. Our next presenter is Julia Leo, who is a Clark Honored College student, majoring in sociology and minoring in chemistry. Julia is a recipient of the Bowerman Scholarship and works as a class encore leader for the general chemistry sequence and as a health promotion student coordinator at the University Health Center. She's worked with under the mentorship of Claire Evans from the sociology department on her project, Quantifying Diabetes Disparities related to American Indian and Alaskan Native residency on reservations. Take it away, Julia.
All right, let me pull this up real quick. Okay. Hello, everyone. My name is Julia, and today I'm going to be talking about how I quantify the diabetes disparities related to American Indian and Alaskan Native residency, who I will refer to as AIAN for brevity, that are living on reservation land compared to those that are living outside of these areas. So there's well-documented disparities between AIAN and other racial groups as a whole when it comes to health outcomes such as diabetes, but not much is known about the disparities that exist within this group due to lack of research. For general overview, the Indian Health Service says that 25% of AIAN males and 30% of AIAN females have been diagnosed with diabetes. This makes it their fourth leading cause of death. And since diabetes is comorbid with diseases like, or other conditions like obesity and cardiovascular disease, this means that it can lead to other compounding health effects that can lead to overall poor health outcomes. Some risk factors for diabetes include inadequate nutrition, stress, and poor maternal pregnancy conditions. Though these may seem like individual level risk factors at first, the fact is that there's a lot of social context that put people at especially higher risk for having diabetes by providing them with extra risk factors. The database that I looked at to help me find the actual correlation is the National Survey on Drug Use and Health. This is an annual survey that measures substance and drug use, as well as health outcomes such as in cardiovascular disease, cancer, and of course, diabetes. It is also a representative sample, which means that any findings from this data can be applied to a larger population. So although the entire US population was not sampled, you could likely take many of these findings and apply it to trends that would appear in the entire population. I looked at the 2015 to 2018 series of this data for my analysis. The two variables of interest in this data is the main predictor, which are American Indian areas, and also the outcome of interest, diabetes. In American Indian areas, this includes federal and state reservations, as well as statistical areas, which include land that federal and state tribes live on, but are not considered official reservations. It also includes reservations that live before Oklahoma statehood, which are the Oklahoma designated areas. And for the outcome of interest, these are self-reported responses on whether participants have diabetes or not. So because this is a binary outcome, it means that you either respond yes to having diabetes or respond to no as having diabetes. Because it is a binary outcome that we're looking at, this makes it a good fit for logistic regression models. I ran a total of 6 of these in 2 different model sets. For model set A, this would include models 1A to 3A, and this set contains imputed data. With imputed data, this means that the respondents themselves did not respond to all of the questions, but the surveyors looked at the respondents' responses afterwards to determine what the most likely answer would have been to the missing data. This imputed data occurs in the family income and education variables. And then for model set B, these do not contain imputed data. So this means that the respondents answered all of the questions and the individual results. For model 1, I looked at the relationship between AIA only and diabetes. And in model 2, I added some controls, which include gender, age, family income, and education. Adding these controls can really diminish any confounding factors that may exist. So for example, if there were an age imbalance within AIAs where there's an older population in these areas, then it would appear that there is a diabetes disparity when in these AIAs, when in reality it's due to an imbalance in age. So then through this, we can really nail down the disparity that exists from AIA itself and not any other variables. In model 3, I added metropolitan status to the list of control variables, and this is because a lot of reservations are typically in more rural areas, so we also wanted to control for any effects that may come from metropolitan status. Now for the resulting models, we found the odds ratios. The odd ratio, essentially, it compares the likelihood of having the outcome of interest relate with the presence of the main predictor compared to the likelihood without the main predictor. So when I say that model 1A has an odds ratio of 1.595, this means that AIAN living in AIAs are 1.595 times more likely than those outside of these areas to have diabetes. In model 2A, we see that this ratio increases a bit so that the disparity is greater than we may initially have thought. And then in model 3A, it diminishes a little bit after controlling for metropolitan status. The key thing to note is that all of these data points are statistically significant. So this is proving that, yes, this is likely a disparity that exists not due to chance. When we compare this to model set B, the overall trends still exist, though the absolute values themselves of the odds ratios are a little less than their corresponding parts. But despite this, all of these data points are still statistically significant, and the fact that model set B excludes any imputed data means that this strengthens findings that we found and that the trend likely is true.
About 5 minutes left.
So just to reiterate, all the models show that there is a statistically significant correlation between living in AIAs and having a diabetes diagnosis. And the test for robustness really helps support these findings as well. When we're looking at the numbers themselves, this means that AIAN and AIAs are likely to have between a 1.584 to 1.764 times greater likelihood to have diabetes than those outside of these areas. Some limitations of the data is that the data set does not distinguish between type 1 and type 2 diabetes. These pathologies for these different types are different. So when we're trying to determine what the causes for the disparities we see are, we're missing the context that will be able to help that will help us pinpoint what exactly is causing these disparities. So it makes it more difficult to see exactly how the disparity exists in these groups. There's also potential for underdiagnosis since individuals had to self-report, but if there were barriers to accessing healthcare, then they may still have the condition, yet lack the diagnoses that would give them a yes response for diabetes. And then finally, diabetes rates vary greatly by tribe. So the findings in this research may not apply the same to each tribe because the actual disparity may be greater or less. This really depends on community context and factors that surround that community, since not every tribe undergoes the same conditions. Despite these limitations, though, the large sample and also the test robustness really solidify the fact that there still is a disparity, and that itself gives us enough information to try to dig further. For future research, now that we have quantified disparities, we would want to look at the qualitative explanations for these disparities, because there's evidence that something in the social environment will increase risk of diabetes for those living in these AIAs. And so research such as case studies, historical analyses, and field research can really give us more information on what specific mechanisms are causing some of these disparities. Once we have this data, then we're more able to tailor our public health policies and interventions to account for these disparities and find the most effective way to help mitigate disparities so that we know we can support those in our population. And I would like to thank Professor Claire Evans for serving as my primary thesis advisor, as well as Professors Kenneth Doxey and Barbara Mossberg for serving on my thesis committee.
Thank you so much, Julia. I think I remembered to unmute myself this time. So we can move on to our last presenter of the morning before we go into our Q&A section. So Arden Saravis is an international studies major with a minor in mathematics. She's a senior who's been working with Claire Evans from sociology on a project titled The Correlation Between Stigma Stemming from HIV and Antiretroviral Packaging, Design Recommendations for Introducing Discrete Packaging for Adolescents in Western Kenya.
Thank you. Okay. Just 1 minute, sorry. Can you hear me all right? Perfect. Good morning, I'm Arden Saravis, and today I'll be presenting on the correlation between stigma stemming from HIV and antiretroviral packaging, design recommendations for introducing discrete packaging for adolescents in Western Kenya. Human immunodeficiency virus, also referred to as HIV, is a virus that spreads through bodily fluids through actions such as unprotected sexual intercourse, sharing needles, and can be transmitted from mother to child through the birthing process and breast milk. The medication for HIV, antiretroviral therapy, also known as ARV or ART, is a cocktail of several drugs that reduce the prevalence of the disease in human blood, stabilizing the viral load to a level that allows a patient to live a near symptomless life. However, the effectiveness of ARVs depends on stringently following a drug regime. As displayed in this graphic displayed on the screen, researchers concluded that taking at least 95% of all ART doses is widely regarded as a standard benchmark for adequate adherence. According to this statistic, a patient who takes 2 pills a day cannot miss more than 3 pills a month, which can be quite difficult to do. In Kenya, out of all new HIV infections every year, adolescents and young adults account for more than 51%. In Kisumu, a city in Kenya that serves as the location for this study, approximately 1 in every 5 people has HIV. Only approximately 65% of adolescents living with HIV who knew their status were virally suppressed. There are many barriers that prevent adolescents from taking their medications in a timely manner. However, the barrier to adherence that this study focuses on is the persistence of stigma in every realm of society, including at school, at home, and in the community. A study by Levy et al. Found that secrecy plays a significant barrier to adolescents taking their ARVs in a timely manner. An outstanding fear is that people will recognize their pill bottle and expose their status to the community. Parents perpetrate this idea as well, since most HIV-positive adolescents contracted the infection from their mothers who do not wish for their status to be revealed either. This proliferation of stigma coming from both peers and adults only adds to the belief that having HIV means you must hide your status or become ostracized from the community. There is significant proof that medical packaging interventions improve adherence in patients. These such interventions include the use of blister packs with calendar and time systems, electronic reminders for prescription refills, and devices with feedback and response tracking. These are designed to decrease forgetfulness and increase convenience, and even disguise the medications. One packaging intervention addressed HIV-positive populations, but was geared towards adults, not adolescents. All existing containers fail to incorporate a discrete element in the context of adolescents in Kenya. Developing a casing that would encourage adolescents and young adults to carry their medications in public is key. Due to increasingly high non-adherence rates in adolescent and young adult populations, interventions should focus on this group, since they are the emerging population of sexually active individuals who risk eliciting the continuation of the disease spread. Suppressing their viral loads will lead to stunting the spread of HIV by creating a healthier sexually active demographic. This study looks to identify key considerations for new packaging or casing for ARVs that disguises its contents. It will inform product design for a casing to be used by adolescents and young adults in Kenya to increase their comfort to carry their medications in public in ways that does not decrease the efficacy of the pill. In this qualitative study, we used focus group discussions and key informant interviews to collect ideas and perceptions towards introducing discrete packaging for ARVs for adolescents and young adults. Data was collected over a 2-month period from October to November in 2019. All data collection was held at a referral level hospital in Western Kenya in their HIV clinic due to the large volume of adolescents and young adults that come to this site for treatment and counseling. 4 focus group discussions were held among adolescents and young adults aged 14 to 24, with 42 participants total, as well as 9 key informant interviews with professionals who work directly with the HIV-positive adolescents. The protocol, consent forms, and discussion interview guides were approved by the University of Oregon's Institutional Review Board and Kenya's National Ethics and Research Committee, and all participants provided full written and informed consent, including parental and guardian consent from minors. All interviews were conducted in English. However, some participants chose to answer questions in both English and Swahili. All conversations were audio taped, transcribed, and translated. In order to conduct research as responsibly as possible, only local researchers interacted with the participants and edited study materials to increase understanding and contextualize them in Kenya. The most interesting challenge while preparing for this study was figuring out how to recruit HIV-positive adolescents and young adults while not asking for them to disclose their status while determining eligibility. Since we were working with a particularly sensitive population, this was the biggest priority of the study. We decided to recruit participants from HIV support group sessions by having trained clinical staff tell them about the study. Only those who were interested were connected to research staff after the meeting. This way, we knew only HIV-positive participants were recruited, so we did not need to ask for their status. During the focus group discussions, we used vignettes to guide the conversation. Instead of directly asking, how do you carry your antiretroviral pills to school, we crafted stories about Lucy and Moses, who both live with HIV, and asked the participants in the focus groups to provide advice to them. For example, Moses asks, if you were in my situation, how would you carry your medications to school and not in public? In hopes that the answers would reflect what they would do. The focus group guides discuss themes relating to how adolescents currently carry their ARVs, stigma associated with HIV, ideas they have as to how to create a discrete packaging, and the elements it should have. The interview guides for key informants include focused on the feasibility of developing a new casing from a clinical standpoint. Overall, the findings from both key informant interviews and focus group discussions are grouped into 4 categories: non-adherence, current pill complaints, current storage techniques, and proposed solutions. The participants acknowledged the issues related to non-adherence due to the distinctiveness of the bottle, stating that being on ARVs has prevented them from attending boarding school due to drug searches, have faced stigma after accidental disclosure, and they fear bringing their medications into public. All key informants reported patient dissatisfaction with the current pill and bottle appearance. Participants stated that the pill and bottle were too recognizable, and the noise of the pills shaking in the bottle is too loud and draws attention. One participant shared that the bottles for HIV are easily recognizable from the others. Because of this, adolescents and young adults reported storing their medications outside of the bottle in pen bags, candy wrappers, inside of a Bible, or with a trusted adult at school. Pills must be kept at a moisture-controlled environment, meaning that storing their pills in items such as a pen bag or a candy wrapper can make the drug less effective. Also, participants reported issues with leaving their medications with a trusted adult because sometimes those adults could not be found at the time that they had to take their medication. The participants proposed very creative alternatives for casings. Many participants mentioned carrying a water bottle with a compartment to hold pills in the cap or on the side. Others suggested creating a casing with a reminder element like a watch or an alarm. However, many were concerned this would draw more attention to the item and be disruptive. Many suggested making pill compartments inside of clothing, for example, a compartment on a belt, on a watch band, in a tie, keychain, or in bags.
You have about
Participants, what was that?
3 minutes.
Participants also made recommendations for how the bottle can be improved by pharmaceutical companies. Participants proposed alternatives like numeric, symbolic, and alphabetical coding systems for the different medications so the clinicians have a key to decipher one pill from another, but the bottle will have no distinguishable writing. Others proposed removable labels to take on and off on clinic days, or have all labeling and directions on a slip inside of the bottle itself. Almost every participant in this study stressed the need for soundproofing, whether that means having tight compartments for pills so they cannot move around, introducing a blister pack for the ARVs, or lining the bottles with materials like sponge, cotton, or rubber. Here are some of the drawings that the participants made with their ideas for a new discrete packaging. These results positively link factors of non-adherence to the current pill case due to unwanted stigma and premature disclosure. Findings are consistent with the assumption that in order to increase antiretroviral adherence in adolescents and young adults living with HIV, one important step is to provide the population with alternative or new casing for their medications to increase comfortability to bring their medications with them wherever they need to go. Ensuring this case is specifically designed for adolescents and young adults means that they will be more likely to use this product and feel heard and recognized. The pharmaceutical companies should consider these alterations along with hospitals and clinics who are dispensing ARVs to adolescents. Understanding the consequences of generic medicine bottles for this vulnerable population can lead to innovation and creativity, eventually producing a product that can be distributed to increase adherence and stunt the spread of HIV. I will soon be submitting this report for publishing and distributing a shortened and translated report to the study location hospital and participants. I also created this infographic detailing how adolescents and young adults can disguise their ARVs in public. The infographic shows step by step how they can use materials commonly found for cheap in the community to safely disguise their medications. We also look to send materials for them to use. These include creating a pill compartment on a plush keychain, disguising the pills inside of a candy wrapper, and hollowing out the inside of an expo marker for pills to be placed inside. These will be distributed to adolescent HIV clinics across Western Kenya for patients to use. I would like to thank Dr. Kwaro at the Kenya National Medical Research Institute, Brock Ongili, and Dr. Claire Evans at the University of Oregon Department of Sociology for their guidance and input, and Mokaya Wazir at the University of Oregon Department of Linguistics for his help with translations and context for the infographic. I would also like to thank my research assistants for their dedication to the study and all the hard work they put into producing this product. I would also like to thank the Office of the Vice President for Research and Innovation at the University of Oregon for providing us with the funds necessary to complete this project. Thank you.
Thank you so much, Arden. So now that all of our presentations have wrapped up, I just want to say quickly that I am blown away by the diversity of these presentations and this research, and but I still see a common thread of holistic thinking about research and how to better our world through innovative thought processes that can lead us to better products and better systems in place for global health. So without any more commentary from me, I'm going to open up the floor to questions from our audience as well as questions from panelists to panelists.
And everyone's unmuted now, so you are more than welcome to ask questions of our impressive students. I am in awe, like Kenlei, of your work. It's really, really impressive, and what a privilege to be part of this session with all of you. So yeah, I think that everybody has the ability to speak now if you want to unmute yourself and ask questions.
I'd like to ask a question.
Okay.
Sam, I'm interested in learning more about how you were able, just like a lot of what you talked about was coming from a place of relative privilege. And I was just curious about how you felt while you were talking with other people at the Tijuana, Mexico border.
That's a really good question that I definitely was preparing myself to experience, kind of making sure I was establishing why I was at the border. A lot of people thought I was a lawyer or had some sort of ability to provide them help that I could not do. So it was one of my primary goals was to first establish that I was a student and I was a researcher, and that I could not provide advice or legal assistance and those types of things. But what I really ended up having more conversations about with people were stories about their own experiences. I spent a lot of time with kids and talked with them about things they were curious about. They would show off to me that they could count to 10 in English, those types of things. So it actually didn't really stand in my way at all from connecting to people. And it also didn't put me or any of the asylum seekers I interacted with at any sort of risk or in any uncomfortable position. And I actually feel like while there were moments like the story I shared that my positionality came into kind of full effect and full force, that was not my experience on a daily basis. And if anything, people kind of dismissed that I was there if they weren't interested in talking with me or interacting with me in any way. Hope that answers your question a little bit.
Yeah, that was great.
I have a question for all of our panelists. If you want to take a brief moment to reflect on what you plan to do with this information now that you have kind of packaged it into your final research project, what's next? Are you going to continue using this, continue researching, or just hoping to share it with others?
I can answer this first. As I said, I plan on writing all of my research findings into a report to be published, but I also am interested in continuing this research potentially into a master's level thesis and actually creating a prototype that I can then go back to the same study site and test, and hopefully come up with an actual like intervention prototype or solution that we could distribute to adolescents to keep their medications in for a long-term solution.
I have a question. I would enjoy knowing what each of you, what is the most valuable thing that each of you feel that you've learned from conducting this research that you might not have realized before.
So one of the most interesting parts of the research was applying for IRB approval. And it was so interesting talking with both the IRB entity here as well as the one in Kenya, and seeing the differences between the two and trying to fit both into protocol and research materials that I can use. And that was definitely the most interesting part, and also trying to think of how to discuss or how to not have to ask adolescents about their HIV status. That took a while to think through. And I think that was the most valuable part of the research, just learning about how the IRB process works and now having a good view on that for projects moving forward.
For me personally, I think one of the most important parts about my project in particular was going to a whole different community I've never really been a part of and feeling like I'm able to contribute something meaningful. And that whole process of personal development, as well as understanding how to conduct research internationally, is a really important skill set. And I think it really helped me grow into my plans for the future. So next year, if all goes well, I am planning to help be an assistant English teacher in Japan. So it'll be like another different form of cultural immersion, but it has nothing to do with my research. And so ideally, after taking a year off, I'd like to go back into working in the public health sector within the United States, and potentially or work in a nonprofit sector and advocate for mobile health clinics, or work with a mobile health clinic here.
And is that through the JET program, Mitchell, that you will be teaching?
Yes, it is.
It's a great program. Congratulations.
Thank you.
How about Julia? Do you have, oh, you turned your camera on, so maybe you want to share your thoughts on your learnings?
Yeah, so I am not really a statistics person. I've only taken one course in my 4 years here, but for my research, I needed to relearn how to code statistics. So that was a whole daunting process, since when I did take the class, it wasn't something that I felt like I really mastered or got a solid grip on. But I just learned more about how to reach out to resources and sort of just think through ways of analyzing data, since the process for cleaning the data and getting them ready for the models required thinking through how to code, how to exclude certain variables, and how to problem solve, because sometimes the code wouldn't be online and sometimes it wouldn't work. So you had to go back and really dig through everything and make sure you are inputting the correct letters, basically.
Sam, anything to add?
Yeah, one thing that comes to mind to me is this kind of like this bigger idea of the single story of who asylum seekers are today coming to the border, and how that is largely informed by the rhetoric we're used to hearing and the public discourse that is prevalent in media and in politics today, and how asylum seekers represent a wide variety of people from a lot of different places in the world. And while predominantly people are either from Mexico or Central America, at least during my time at the border, there are people coming from all over the world, including places in South America, Haiti, Cameroon, and that also represent a wide variety of like social class and economic class. The commonality there is that they're fleeing these kinds of this violence that we really can't really wrap our heads around living in the places that we do, and how asylum seekers are placed into this category of kind of voluntary migration, when in reality a lot of these people should be considered forcibly displaced. And the mere fact that they're considered voluntary strips them a lot of their deservingness to be in the United States of America, and as well kind of strips them of their agency and choice to migrate, while at the same time that choice is not necessarily inherent, and sometimes in order to support their families and even survive, they have to leave. And so that dynamic is, in those few words, it's really complex, but that's something I would hope that people think more critically about when, especially with the updated policies that keep rolling out and the way that media is reporting on the crisis at the border, and the different caravans coming through. Yeah.
Thank you. Wow, lots of valuable information gained, and how strengthening it is, right, for all of you to gain this experience early on for the next phase of your journey. So thank you so much for sharing, and thank you for your patience in getting over our initial challenges with the technology. You're all troopers.
We do have about 5 more minutes left for questions, if there are any other questions from our audience members.
I have a question for Julia. I was interested in learning more about how you decided on researching American Indian and Alaskan Native populations.
Yeah, so I think when it comes to hearing about disparities in general, that's the one that people tend to hear less of for various reasons. So for example, most likely less people know or have a friend that is of that identity. And also it's not really covered as much in mainstream media either. Although hopefully that will be changing soon as people become more aware about intersectional issues. But I decided that from my own lack of knowledge that I want to really learn more, because there's a lot of various forms of oppression that AIAN people do face, and that there seem to be less research into this. And so I wanted to add more to this field, because I know there's a lot more looking at other identities. So just for my own educational experience and for really getting more information out there, I thought this would be my best group to look at. That, and I had a pleasant experience visiting a reservation, I think a year or so ago, just about a little over a year ago. And that really made me see that I am interested in learning more, because it's something that I never really was able to learn about through my daily experiences.
Great.
Thank you.
What a privilege it was to be part of this, all of you. Thank you so, so much.
Yeah, I just want to say again how immensely proud I am right now to work at the UVO and have a chance to talk with you, and also having known you guys for a few years for some of you now. I'm just really, again, blown away. You personally have hit to a few of my identity markers that I am still coming to explore and understand a bit better. And now looking at it from a health perspective, I'm learning a lot of new questions I should probably be talking about in my own life. So thank you.
Yeah. Kenlei and I feel really, wonderful to be part of this specific session, because we do know all of you. So it added extra fun for us to be assigned to this session to engage with all of you. So thank you for the privilege.
So with that, we have about 2 minutes left, but I want to challenge all of you to give me one sentence summarizing your experience, starting alphabetically with Julia.
I would say, from my experience, it was informative, eye-opening, and gets me to think more critically about what influences our health outcomes.
Fantastic. Arden?
My experience helped me understand the importance of incorporating local health workers into research when you're working in a context that you're not exactly familiar with, as well as I said, the IRB process, and basically how to put on a research design that's sound and ethical.
Thank you. Sam? Or Mitchell?
I'd say my research experience was turbulent. I feel like it never went the way I really wanted it to, until like I found out, like it's just like I was always finding new different things I was interested in, and it was hard to really pick a specific topic for me. And so I was just adapting from one thing to the next until I found out mobile health clinics is really the thing I wanted. And that for me is just the whole research experience. You never know what you're going to get. And once you find out what you want, it just makes that process seem really silly in hindsight.
Fantastic. Sam, do you have anything to add before we wrap up?
Yeah, it's hard to put into like one concise sentence, but I guess for me, a major takeaway and thing that I am carrying with me now is how encouraging it is to see the development and the generation of these local community support networks, and how effective they are, and how they operate locally and transnationally, and how solidarity is a really powerful very powerful feeling for both people who are offering that support and for those who are receiving it.
Thank you so much. Again, another thank you to all of our panelists and all of our guests today. We're going to have to wrap the session up for today, but this whole session has been recorded, and Lanch and the rest of the UESS team will be working to get it on the UO's YouTube channel under a specific series for the UESS Undergraduate Research Symposium. This has been so enlightening, and thank you again.
Thank you, everyone. Have a wonderful day.
Thank you so much.
Thank you.
Thanks for your patience.
Thank you for your time.
Again.
Yeah.